Technologies. So first I invite Dr. Ashapurna borgohain. She's a vitreoretinal consultant at Chaitanya Institute, Palarivattam. She'll be telling about the basics of OCTA. So over to you, Dr. Asha.
Thank you. So OCT angiography is a non-invasive imaging modality, which is basically an extension of the OCT and which visualizes perfused retinal and choroidal vasculature by using motion contrast in a depth resolved fashion. Although OCTA is not considered superior to FFA ICZA, but it has certain advantage over FFA. Like it does not use dye, so dye-related complications are avoided, and patients who are contraindicated for FFA ICZA can undergo OCTA. As it does not show any leak, pooling, staining, so vascular details are better delineated, and it eliminates the narrow transit time of dye coming in and flushing out with FFA and ICZA. It can image the retinal capillary plexus at different levels. No other modality can do. And it also helps in quantification of certain parameters. So coming to the principle, like OCT, it acquires multiple A scans which combine to form B scans. And when these B scans are repeated at the same location at a short succession, temporal changes from moving objects can be picked up. And this multiple adjacent B scans over extended regions can be used to form a 3D retinal structure, and we can visualize blood flow. So this brings to an important concept called the decorrelation signal. This is basically the subtracted signal caused by blood flow, and it is due to difference in difference of signals due to the moving particles as compared to the static tissue. So the interscan time is the time between T1 and T2. And the importance of this interscan time is that if we use a longer interscan time, it gives a better chance to pick up slow-moving vasculatures like the polyps and microaneurysms. And vice versa is also true for short interscan time. But most of the machines, they have a preset interscan time to minimize artifacts and display flow. The commercially available machines uses various OCTA algorithms. The importance is that when we read a report, when we read an OCTA report, it can lead to different diagnostic interpretation if we see from different machines. The 4 distinct capillary plexuses which we can see in OCTA are the nerve fiber layer plexus and superficial vascular plexus, which is seen in superficial vascular complex, and the intermediate and deep capillary plexus, which together form the deep vascular complex. When we get images from an OCTA, the raw data from OCTA, we can see it as an en-face image or section images. The en-face image can be of 2 types. It is the structural en-face image, and we get the OCTA image. When we interpret an OCTA, the first thing which we should see is whether the right area is imaged or not, whether the pathology or the area of interest is imaged. Then we look at the en-face image. Any abnormality which we can pick up any abnormality in the OCTA image, but we should make sure whether it is a real image or real pathology, or is it some projection artifact or any other artifact. So we look at the segmentation lines, whether it is segmented at the right place. Once we know that it is segmented well, then we look at the flow overlay, whether it is corresponding, whether the pathology is corresponding to some flow there. This is the normal appearance of superficial vascular plexus and the deep vascular plexus. These 2 vascular plexuses are most commonly involved in retinal vascular diseases. In fact, OCTA is the only modality which can visualize the deep capillary plexus, which is the first to be affected in many vascular disorders. So abnormalities in these 2 slabs can be seen as either abnormal presence of flow like the NVEs, or abnormal absence of flow like capillary void areas, and abnormality in vessel symmetry like we can see these microaneurysms. The avascular zone and choriocapillary slab usually does not show any vascular channels. Anything there is pathological. These 2 slabs helps us to pick choroidal neovascular membranes. Little bit about OCTA analytics. OCTA helps us also give some numerical measurements which helps to objectively assess disease severity, progression, also helps in documentation and follow-up of a disease. Like the vessel density, vessel length density, fractal dimension, and we can measure the area of foveal avascular zone. Coming to artifacts, these are the unwanted extra findings or missing findings, which is seen in any imaging modality but is more prevalent in OCTA. And it can challenge correct interpretation and reproducibility. So why do we see these artifacts? It can start from the very beginning, like when we acquire the image itself, it can like defocus artifact and decentration artifacts, or due to some bulk motion like eye motion, head motions of the patient, or some intrinsic property of the eye or image processing or during display strategies. So this is the most common artifact which we see in OCTA, the projection artifact. It is the replication of superficial layers in the deeper layers. But due to the advanced technologies, the advanced softwares, this projection artifacts can be removed, and we can get only the abnormal, only the pathological appearance. So another artifact is the motion artifacts, which can be due to bulk movements of the eyes, head and neck. It is seen as a section in the en-face image, and corresponding flow signals will be very dense. Different types of motion artifacts are double lines like crisscross patterns or blink artifact, where a complete area in the en-face image will be missing. When there is obstruction to the flow, to the passage of light, there can be appearance of flow void areas in the deeper layers. When the beam hits some obstruction like vitreous floaters or vitreous or any other opacities or even drusen. So how to be aware of that? So when we see any hypodense area in the OCTA in the en-face slab, we should always see in the structural OCT slab. If in the structural OCT slab the same hypointense area is there, that suggests that the beam was obstructed and it is not a real hypodense area. So this OCTA algorithms, they automatically segment slabs with definite retinal boundaries, and the vessels within that are projected as en-face image. But these were developed using healthy eyes with defined retinal layers. And segmentation failures can be seen if these retinal layers are altered, like in ERM, edema, ischemic retina, or PED. But we can correct it by two ways, either by slab selection or by manual segmentation. So this is a small video. This is how we segment. These are already selected slabs. We can either click in the slabs like the superficial vascular complex, the deep vascular complex, or we can manually retrace the boundaries like in this. We have to go to the choriocapillary slab, and then we can select a specific width, and then we can trace it. Here we can see that when the slab is placed properly, we can see the network. But if it is scrolled downwards or upward, we might not see the network. So indications of OCTA, it has been a valuable tool in wide range of ocular pathologies, most commonly used in diabetic retinopathy, AMD and PCV, which will be dealt in the subsequent talks. It can also be used in retinal inflammatory disorders for diagnosis as well as follow-up. In hereditary disease, mostly in BEST to pick up the CNVMs. In retinal tumors to differentiate choroidal nevas from choroidal melanomas. In retinal capillary hemangioblastomas. So coming to an end, OCTA has become an important tool in retinal vascular imaging. However, we should be aware about the different artifacts, and we will get meaningful data from OCTA only if we know about the artifacts and we have some proper training. Thank you.
Excellent coverage of the basics by Dr. Asha. Next, when we talk about OCTA, it's always, there's a preconceived notion that it's only something a retina specialist